Hey guys, we're going to get started with a brief review of the upper limb anatomy and a little bit of the hand. We're going to get started here with the brachial plexus. You can see our nerve roots here are C5, C6, C7, C8, and T1. You can see that those are going to give rise to your superior, middle, and inferior trunks. Then those are going to give rise to divisions, which are anterior divisions here, and your posterior division, it's right here. So you can see your posterior division is going to give rise to your posterior cord. That guy is going to give rise to your radial nerve following this way. If we look at the anterior divisions, let me switch colors here for you. You can see that that's going to turn into your lateral cord here and your medial cord. Those are both going to give rise to your median nerve, so they'll both contribute there. Your lateral cord also gives rise to your musculocutaneous nerve here, which is going to pierce your coracobrachialis muscle. You also are going to see your ulnar nerve come off of your medial cord, And let's see. And then we also have our axillary artery, which obviously is this big pink guy in this picture. But you can see that it's massive and it flows right through in where the brachial plexus is. So it's a quick review of the brachial plexus. When we talk about damage to the upper or lower parts, we're talking about, so this would be upper, and then you could say damage to this area would be lower. So that's what we mean when we're talking about upper damage or lower damage. We're talking about those nerve roots. So C5, C6 would be something like an upper brachial plexus injury, could cause Erb Duchenne palsy, which presents kind of like somebody's asking for a waiter's tip presentation. This can happen when there's an increased angle between the neck and the shoulder. Can happen during a really rough delivery or a fall where the person's head kind of goes to the side and really increases that angle. Damage to the lower plexus, something like C8 and sometimes involvement of T1, can cause Klumpke paralysis, which presents kind of like a claw hand. You can also have some issues. A lot of times Horner's comes up with T1 injuries if you have T1 involvement. You also have this lower plexus injury mostly affects the hand muscles, so that's why you kind of see that claw presentation. Usually happens from something like somebody falling and trying to really reach out and grab something, and it can damage that area. And then there's also something that's not quite as common, but it does happen. You can have damage to the superior trunk. They call this backpack palsy or rucksack palsy, depending on the country you're in. But that is because of pressure that's put on the superior trunk here. So if you could imagine a book bag or something really kind of pressing down here, you could have some paralysis, weakness, that kind of stuff, just because of this compression here. We typically see that a lot in military professionals, people that are kind of forced to carry around heavy stuff. And you can see it in other people, backpackers and kids carrying way too much in their book bag, that kind of stuff, or improper carrying. Okay, so now we're going to talk about the elbow a little bit here. So the elbow is a joint that is made up of your humerus, which is this guy here. Let's see if it'll work with me. So that's your humerus. You can see that you've got some epicondyles here. This is your lateral, and this is your medial. Those are attachment points of tendons that help to obviously stabilize the joint, but there's a lot of issues that can kind of come in there. You can end up with lateral epicondylitis, which is an inflammation of the epicondyle or a tear of the tendon that attaches there. You can also end up with medial epicondylitis. And just a quick note, the medial epicondylitis is also known as golfer's elbow due to the movement that typically produces pain and the movement that golfers are doing frequently to obviously golf. But you can end up with a tear to the tendons that are attaching those flexor muscles there, and that can cause a lot of inflammation. You can also have lateral epicondylitis, which is known as tennis elbow. So that's where either you just have general inflammation or a tear with the extensor tendons. So it's a lot of, like, they say tennis because you think, a backhand movement. And so obviously that can be very painful, but you usually see it in people that play a lot of racket sports. So we also want to talk about the nerves that are coming through this joint here. Obviously, if a nerve needs to come through a joint, it's going to be at a little bit of risk because it needs to move around. But you can see our radial nerve, our ulnar nerve, and our median nerve here. So it's also important to note where those nerves kind of cross that joint, especially if you were to have a fracture of one of the epicondyles, specifically the medial epicondyle maybe came down pretty hard on, a desk or something as you're falling. You can have a lot of damage to your ulnar nerve here. As you can kind of see, so in this picture you see that the ulnar nerve comes here and the radial comes over the top. You've also got some median innervation here, but the ulnar nerve specifically at a pretty good risk of damage if you were to hurt or fracture this medial epicondyle. So those nerves continue down to the hand. You can see the median nerve here, and then you can see your ulnar nerve here. So you can see that those two nerves are going to continue. Those are going to be major supplies for the hand and the cutaneous innervation as well as function. So you can kind of see in this picture here that there is the median nerve really covers fingers 1, 2, and 3, and then a little bit of 4 as well. But you're specifically the 4th and 5th finger, or the outside edge of the 4th and then the 5th finger, are supplied by the ulnar nerve, and then the radial nerve covers that 1, 2, 3, and a little bit of 4, but on the dorsal side of the hand. So you can see that here. So this is, you can see that there. So an important thing to note is carpal tunnel syndrome. So you can see this is our median nerve here, and it's in there with a lot of stuff. You got your flexor digitorum tendons, you got your superficialis, your digitorum. You have a lot, and that's all held in place by this flexor retinaculum, which is also called the carpal ligament. So you can see that there's not a lot of space for this all to kind of go along. So a lot of people can have some damage and irritation when this all gets a little bit inflamed. That can happen from things like typing at a desk, or the angle of the wrist just not really being as proper as it can be. So there are some behavioral modifications that you can make to help fix this, but if worse comes to worse and that does you elect to have surgery because none of those are working for you, they actually go in and release this tendon here, so that flexor retinaculum gets released so that there's room for everything to kind of breathe and hang out. All right, we're going to go through the bones of the hand really fast. So these guys down here are your carpals. Let's see if this wants to work for me. Your carpals, you got your metacarpals, and then your phalanges. So you can see it's counted as we've been kind of talking about 4, 1, 2, 3, 4, and 5. So these are all of our bones in kind of the at the base of the metacarpals, but really the kind of almost the wrist bones here before you enter into your radius and ulna kind of thing. So your scaphoid, which is this guy here, is really prone to injury, especially if you were to fall on your hand when it's fully outstretched. We all know that as the Fuchs injury. But it can really be prone to damage, and you really do want to be careful of the radial nerve, which runs just about right there alongside it. All right, so lastly, let's talk about a little bit of digital anatomy. So you can see here, obviously, this is a clinical thing that's happened, but if we discuss the anatomy here, you can see there's these tendons that go on the finger, and you can see this is your flexum digitorum profundus. It goes through your superficialis, so this is your superficialis here. Let me use some better colors to it. So our superficialis goes around like this, but it leaves a hole for the profundus there. So this helps the finger movement. This kind of like woven pattern allows the finger to flex and extend properly. So this picture here is actually an image of what we call mallet finger. Some people call it baseball finger. But it is a result of hyperflexion of the DIP joint, so the joint that's like here. And this injury happens because the extensor digitorum tendon is actually avulsed, so it breaks that tendon, and it doesn't allow that proper movement of the hand. All right, guys, thanks so much.